Okay. Professor? You hear me? Can you hear me? Hello, do you hear me? I could not hear you. What's the problem? I can hear you. Okay. I could not hear the professor at all. Yeah, I can hear you. Các cái lửa sau đây là lục biểu.
Quản lý audience có panelist cho nên là cùng chào ở đây chúng ta gặp chào cho nên vào khai mắt của cha mẹ thì
Cô cào xa lay đỏ hả?
Không ạ, cho nó bay lên với nó họ.
Good afternoon, valuable healthcare practitioners. Greeting to you all who attended the webinar and joining our Facebook Live. Today is the day of level F Aliginate role in GERD management online event. First and foremost, I would like to introduce myself as I am Dr. Teng, Sales and Marketing Manager from Reckitt Healthcare TKS Myanmar. And I represent SMC for today's online event. Before the event, I would like to announce the agenda. Agenda 1, opening the online event. Agenda 2, opening speech by Professor Nguyen, retired professor and head of gastroenterology department, Manly General Hospital, for the event of level F Aliginate role in GERD management. Agenda 3, scientific information will be delivered by Associate Professor Monthura Maniratnapong, MD/MS, Division of Gastroenterology, Faculty of Medicine, Savarajit Hospital, Mahidol University for the topic of Level F Aliginate role in GERD management. Agenda 4, question and answer section between attendance and speakers. Agenda 5, Carvis control presentation and closing the online event. According to Agenda 1, I would like to announce that the online event for Level F Aliginate role in GERD management is now open. And I would like to invite Professor Nweni for the opening speech.
So, good afternoon, all my seniors and juniors and all the colleagues who attend these today's very informative webinars. And also good greeting from the Mandalay to our eminent speaker, Ms. Montira Monia Ratanapon from Thailand. And today is a very important day for us, and having this webinar, a level up Aliginate role in GERD management. As you all know, GERD is a global disease and an increasing incidence worldwide. Though we have the many obstacles in the recent years, but it continues to be among the most common gastrointestinal disease seen by our gastroenterologists, surgeons, and family care physicians. And it has a very varied clinical presentations and diagnostic tools and evolving trends of the approach to the patient's management. And during this time, when PPI management has increasing concern, though it is remains the medical management of the choice, medicine of the choice, but there are some questions about its adverse effects and safety in long-term use, and particularly in the COVID infection and other things is long-term use can cause the increasing incidence of enteric infections. Today, we have the most eminent neurogastroenterologist of our Southeast Asian region, and to discuss on this topic and on updated and clinical evidence-based recommendation and practical guidance of management of GERD. Our speaker today is Associate Professor Dr. Montira Monia Ratanapon, MGMS, from Division of the Gastroenterology, Faculty of Medicine, Saviraj Hospital, Mahidol University, Bangkok, Thailand. She is also the Faculty of the Medicine of the Saviraj Hospital and Mahidol University, and she has a very prominent and active neurogastroenterologist holding the postdoctoral fellowship in modality and gastroenterology, and had a clinical research award from the American College of the Gastroenterology on 2010. She has many publications and presentations and works on the field of the, not only on the field of the gastrointestinal modality disorders like the GERD, irritable bowel syndrome, functional dyspepsia, and also the other GI diseases like the chronic hepatitis and gastrolymphoma and gastroparesis and so on and so forth. Without much ado, I'd like to invite our prominent speaker, Dr. Associate Professor Montira Monia Ratanapon, to present your very interesting topics.
Thank you very much. A nice introduction, Professor Imenma, and I'm very glad that we can see, our face together, although it's just online. But I hope you enjoy with my talk. Okay. Hi, good afternoon from Thailand. I'm very happy to have you here today, and I would like to say hello to our doctors and professors over there in Myanmar, and I hope you are doing well today. And I would like to thank you, RB and BKSH, for providing this good session today. And my my mission today is to talk about level up Aliginate role in GERD management. So let's start with the agenda today. The first agenda is I'm going to talk about the recently published GERD guideline and consensus, and to see is PPI still the mainstay. The second one is the long-term side effect of PPI and how to avoid. The third one is Gaviscon can be an appropriate rescue therapy for patients reducing or stopping their PPI. And finally, there are any other position of Gaviscon. Okay, let's start with the recently published GERD and guideline and consensus, and if PPI is still the mainstay. Review a lot of published GERD guidelines recently in these last 5 years, and from 2017 up to this year, you can see that there are many, countries or organizations like a WGO guideline in 2017, Seoul and Thailand guideline in 2020 in management of GERD. Last year from the Southeast Asian region about the consensus statement and recommendation on the management of mild to moderate GERD. The latest one are from the US, the ACG American College of Gastroenterology, a clinical guideline for the diagnosis of and management of GERD, and finally the AGA clinical practice update on the personalized approach to the evaluation and management of GERD with an expert review. And if you look at the question that is PPI still the mainstay, yes, all the guidelines say that. They are also, PPI is still the hero or heroine for the patient. And why is that? So we have to look back at the mechanism of PPI that many of you here also know already, but I would like to, talk it in brief here. In our stomach, there are, parietal cell lining, especially at the antrum, right? And if you take a look at the parietal itself here, at the bottom of the cell, there are some receptor that was activated by acetylcholine, gastrin, and histamine. And if you give H2 blocker to the patient, if you block here, right? But in real life, if this receptor was activated, then there are some, mechanism here, intracellular mechanism of parietal cell, and then the acid will be produced and ready to be released from the cell here, past the proton pump here. And the PPI will be inhibit the production of stomach acid by inactivation of active proton pumps here, which is found within the parietal cell of the stomach. And this suppress both stimulated and basal acid secretion produced by acetylcholine, gastrin, and histamine relief. And PPI will block the final common pathway of acid production, meaning that they are more effective than treatment targeting one pathway such as histamine, right? So it's kind of very powerful medication, okay? And if you look at the effective of the PPI or the impact of PPI in terms of GERD, it will be different from erosive and non-erosive reflux disease. For example, if you look at the erosive esophagitis healing, it seems to very impressive, like 83% in PPI, and compared to 28% in placebo group, with the number needed to treat just only 2 cases. But if you look at another outcome, for example, heartburn relief plus or minus esophagitis, heartburn relief without esophagitis, or regurgitation relief with or without esophagitis, there will be decrease the impact of PPI and increase the number needed to treat. And so how many cases that have erosion? The use of PPI is justified to heal lesion in patients with erosive reflux disease, but there are minority of them, just only around 30% from one report. And the ability of PPI to completely control symptoms of uncomplicated non-erosive reflux disease is less convincing. So even if it's less convincing, I think it doesn't matter if, it's not a burden for the patient in terms of, you have to take it every day, or about the cost, and most importantly is the safety. So we know about the side effect of PPI for a while, and we are going to learn how to avoid it here. Okay, let's talk about the adverse effects associated with PPI use. This is published in Mayo Clinic proceeding around 4 years ago. The most commonly associated effects including abdominal pain, diarrhea, and headache. And more recently, there are some report about nosocomial pneumonia and COVID-19. That is a case control study that found that patients who are taking PPI is more likely to get COVID-19 compared to non-PPI user. For example, things that people talking about a lot about the PPI side effect is C. difficile infection, non-typhoid salmonella, Campylobacter species, or spontaneous bacterial peritonitis, and also kidney disease, including acute intestinal nephritis, acute kidney injury, and chronic kidney diseases. Other than that, they're also talking about dementia, hepatic encephalopathy, B12 deficiency, something like that, but the evidence is not very convincing. So take a look at the evidence of this. So most of the time, the study was conducted in terms of, observational study, or population-based cohort study, or case control study. Just only moiety was a report, and RCT conducted present in 2019, and this study was conducted with a 3 years duration, up to 17,000 patients here, and they report that it increased risk of chronic kidney disease with the evidence level of 1B. Other than that, most of the time is observational study, but the evidence is not that bad. It's 2A, 2B, for example, is a report of chronic kidney disease, acute kidney injury, and acute interstitial nephritis. Clostridium difficile infection by RCT is increased the risk up to 2.26. Is 1B, and another 1B is community acquired pneumonia, not just only nosocomial pneumonia anymore. A little bit, but this one is not significant because the CI is so the evidence is there, right? So there are some report that we have to be concerned about the side effect of PPI. And the risk factor that people need for PPI prophylaxis is if they are old, like us, more than 65 years old. So old people will come with many diseases, and if they have a prior ulcer or ulcer complications before, this will be indicated to have long-term PPI. And also, even if they don't have ulcer before but have a high dose NSAID or Coxib plus multiple NSAID or Coxib or steroids or SSRI, warfarin, low-dose aspirin in elderly patients, or plus with ticopridine or clopidogrel use in high-risk patients, or acute NSAID Coxib use in patients taking chronically anticoagulant or antiplatelet drugs. So most of them old and have many diseases. This is a very vulnerable group to have complication, right? So the main causes of misuse of PPI therapy that we can avoid and to decrease the use of PPI, including monotherapy of steroid like SSRI, low molecular weight heparin or warfarin or ticopridine or clopidogrel alone without any other risk factor. These are not the indication for long-term PPI use. NSAID, aspirin, Coxib, used in patient who has less than 65 years or without other risk factor. Straight ulcer prophylaxis in non-ICU patient. Wrong diagnosis of acid-related disorder or over-treatment of functional dyspepsia. Patient with chronic liver disease and portal hypertension. Improper prescription of PPI during hospital stay or continuation of PPIs prescribed inappropriately upon hospital discharge, and absence of regular doctorly evaluation of chronically PPI use. And I think this one is very important and not, I mean, it's easy to decrease the use of PPI if you re-evaluation them regularly. Other method to reduce PPI is use another agent. Like if you use Gaviscon, is it possible? So take a look at the evidence here. First of all, we have to know that like how much or how many patients that suffer from this problem. Here is a population-based study survey from the US from 70,000 persons about the prevalence of GERD in PPI refractory symptoms. So they found that GERD symptoms to be very common, like 2 of 5 participants have GERD symptom in the past, and 1 of 3 had symptoms in the past week, and half of the PPI user have persistent symptoms. So the factor associated with GERD symptoms in the past week is female sex, non-Hispanic, white race, and comorbidities. And people who are female, Latino race, and younger age is factor associated with PPI refractory GERD symptoms. So you see that it's not like just only old age, but in this group they have not much comorbid disease, but they are refractory to PPI refractory GERD symptom. So it's a lot of people, right? And if you look at the GERD pathogenesis, you can see that if you have normal EG junction, your lower esophageal sphincter and cruise diaphragm synergy is good. So you have tight hiatus. You have just only physiologic reflux and you have like a rapid acid clearance. You don't have problem with GERD. But if you have instigating factors, for example, obesity, age, genetics, or pregnancy or trauma, it will be have like a mechanically impaired of esophagogastric junction and have the laxity of this attachment, reduce lower esophageal sphincter and cruise diaphragm synergy, increase the distensibility of esophageal sphincter junction, and increase intra-abdominal pressure. And this will be pathologic reflux, like increase the non-transient lower esophageal sphincter relaxation event, poor gas and liquid reflux discrimination, increased reflux volume, proximal reflux, and have like a esophageal hypersensitivity, and they will come to see you with a reflux symptom like a heartburn, regurgitation, or even chest pain. And in case that you have exacerbating and perpetuating factors like obesity, again, diet, neuromuscular dysfunction, and esophageal fibrosis, will your EG junction will be turned to be overt hiatus hernia, and there will this association between the lower esophageal sphincter and cruise diaphragm and have dilated hernia, and will be pathological esophageal clearance, not just only pathological reflux. And one of the mechanism is acid pocket towards the diaphragm. The finding that you can find from endoscopic finding is esophagitis, stricture, metaplasia, and cancer. So what is acid pocket? The acid pocket, the hypothesis is that it occurs as a result of meal-stimulated acid mixing poorly with the chyme in the proximal stomach. And after a meal, the proximity of the acid-secreting mucosa means that the periphery of the gastric lumen is the most acidic, and the buffering effect of food is greatest at the center. So you can imagine that after you taking some food, it will be a ball of food mixing, and around the ball it will be acidic, right? And from the motility perspective, the proximal stomach is relatively mucosal after a meal, being the region where gastric accommodation facilitates storage, thus allowing gastric secretion to form a distinct layer above the cam. Okay, this is the theory, right? Please look at the, the experiment. And here is the pH of the refluxate before eating or empty stomach. In the empty stomach, the pH in the stomach is just only 1.3, while the refluxate is around 2.5 in 40 dyspeptic patients. And after taking a meal, what happened? The pH of refluxate events is up to 1.5, while the pH in the stomach just only 3.2. So how can we explain about this? Here is the discovery of acid pocket. If you put pH monitoring catheter into patient's stomach, this is what you see. Like this is the distance from nostril, right? So here in the stomach, you can see that pH is very low, like 1 point somewhere. And here is in the esophagus, you can see that here is the area or the location of lower esophageal sphincter or squamous junction here. This is the fasting state. And if the patient has some, food, the pH in the esophagus pretty much the same, right? But it will raise the pH in the stomach because you have food to dilute the acidity in the stomach. But at the level of lower esophageal sphincter, there are some, like a drop of the pH to be 1 here. Here they call it acid pocket. And if you would like to it like a more obviously, you can see here they insert the electrode into the patient's stomach, right? And this is the level of squamous columnar junction. The red color indicate the low pH, while the blue indicate high pH, and the yellow and the green is the in the middle. And you can see in the fasting state again it's acid, right? And the esophagus is base. And after taking a meal for 3 minutes, you can see the changes in the stomach that is turned more base to be like 4 to 6 here. When you're going to like 17 minutes and 34 minutes or 43 minutes and 47 minutes, you can see a line of red color here at the level of squamous columnar junction or LES here. It's turned to be red. That means there are some acid pocket even in healthy volunteer. And imagine if the patient has hydrohernia. So here is the healthy person. The acid pocket is in the stomach, so you are fine because your stomach lining is tolerate to acid, right? But if you have small hernia, some of the acid pocket is above the diaphragm. And if you have larger hernia, most of the acid pocket is above the diaphragm. So it's obviously that is a risk factor for develop GERD in patient who has very large hernia. And if we would like to use Aliginate in patient, in this case, we have to know what is Aliginate. Alginates are the hydrocolloids of vegetable origin that occur as a structural components in marine brown algae. The principle is a water retention, gelling, emulsifiers, stabilizers, and their ability to form viscous solution and gels coupled with their safety have led to a variety of uses in food, cosmetics, and pharmaceutical products for over 100 years. And you have to know that different alginates have different physical chemical properties. Alginate graft formation in the product is not just only pure alginate. There are also salt about like a calcium bicarbonate in the product. So when you get the product and it meet with acid environment in the stomach, both alginate salt and alginic acid will be precipitated to form a low density but viscous gel here. and the gel forms rapidly on exposure to gastric acid, occurring in vitro within seconds and a few minutes in vivo. And the ability of calcium, it will increase lab strength, is attributed to its ability to cross-link organic acid polymers, allowing the gel to form an egg box structure which has great inherent strength. And the bicarbonate act as a gas generating system. The CO2 bubbles which form in the presence of gastric acid become entrapped within the forming gel matrix and converting it to a foam and providing buoyancy is often described as a raft. So you can imagine like the ball of the food that you take and they have acidity around it, and you have this raft around them again because they are interaction with the acid, right? So that also the theory. And so look at the experiment again. This is a postprandial reflux suppression. So this study was to visualize reflux suppression by Aliginate antacid compared with non-graft forming antacid using MRI and to determine the feasibility of pH impedance monitoring for assessing reflux suppression by Aliginate. They conduct two studies. The first one is Gaviscon and antacid were visualized in the stomach after ingestion in 12 healthy volunteers over 30 minutes after a meal by MRI, with the reflux events documented by manometry. And the second study was RCT double-blind crossover trial of postprandial reflux suppression documented by pH impedance in 20 patients randomized to Gaviscon or antacid after 2 meals taken 24 hours apart. And the mechanism of reflux suppression visualized by MRI, they use 12 healthy volunteers, like I mentioned before, and look at the structure and function of esophagogastric junction and proximal stomach were assessed by HRM and MRI. And with two separate tests, they use a mixed meal, like a McDonald's cheeseburger with fries, with a milk drink. Liquid components was labeled by paramagnetic contrast agent. And here is the result. On the left panel here, the Gaviscon Advanced that you can see as a blue color here, compared to a local control, which is just only antacid. You can see that the volume was significantly greater than antacid. That means it's kind of a forming of raft that I mentioned before, and its center of mass was closer to esophagogastric junction and air meal interface. So it's kind of protection in a raft compared to a local control. This is the experiment. And if you look at the concurrent HRM and MRI detection of reflux, the results show that the number of common cavity reflux events on HRM over 30 minutes was significantly less with Gaviscon compared to antacid. Okay, and in the clinically outcome, this is a meta-analysis from 14 study with 2,000 patients, and the forest plot show that Aliginate therapy compared to placebo or antacid that favor Aliginate with the odds ratio of 4.4. Okay, another study is the Gaviscon double action is more effective than antacid in controlling postprandial esophageal acid exposure in GERD patients. This is a double-blind crossover study. Just only 14 GERD patients took 3.5-hour high-resolution manometry pH impedance studies during which they ate a standard meal. It's a double-blind randomized crossover study. They took Gaviscon or antacid with equivalent neutralized capacity, with the primary outcome to determine the distal esophageal acid exposure and the secondary outcome including number of reflux events, proximal extent of reflux, nadir pH of the reflux set, and mechanism of reflux and reflux symptom score with a validated instrument. Here are the demographics. Just only 10 patients that complete the study, and 5 of them were male with the weight around 90. Quite big. 4 of them have LAA esophagitis, and 4 of them have LAB esophagitis. 2 of them have abnormal acid exposure on 48-hour pH study with the mean entry GERD score of 9.5. And this is the result that Gaviscon has, less of distal acid exposure around 0.7 compared to 8. This is significantly less than antacid group. And if you look at percentile pH below 4, Gaviscon also achieved, less percentile pH below 4, which is indicate that you have a good control of GERD. And for the nasal reflux pH, here is present in mean per subject. You can see that along the study period from 60 minutes up to 180 minutes, Gaviscon can raise more pH compared to antacid. So the conclusion of this study states that Gaviscon is more effective than an antacid without alginate in controlling postprandial esophageal acid exposure, and this suggests that Gaviscon's main effectiveness relates to its co-localization with and displacement or neutralization of the postprandial acid. And so can we use it or use alginate to replace PPI? Here is the outcome of more than 1,000 patients evaluated a prospective audit of step down or step off after 12 months. They include a patient with GERD or non-ulcer dyspepsia who had been on PPI treatment for more than 2 months, and they will provide with the information on the causes of dyspepsia and heartburn, lifestyle advice, and alternative treatments. And they were invited to change their medication to either lower dose PPI plus alginate, or we call it step down, or stop their PPI and replace with alginate, we call it step off. The alginate dosage was 4 times a day for 2 weeks and then PRN. The patient will follow up after 12 months to evaluate PPI dose and alginate use. And the result, you can see that step off or no PPI at all is around in 500 cases. The mean use of alginate just only 1.4 bottles. In case of step down, 400 cases, they use 2.2 bottles. And in case that has no management, around 200 cases, they use 1 bottle. And increased PPI just only 10 cases or 0.8%. So in this study, they show that up to over 80% of patients were able to reduce or stop their PPI 1 year after the educational intervention program, and the average of 1.6 bottle of alginate were used per year. So it's kind of very impressive, right? You might argue that okay, most of them will better anyway, but okay. So this is another extreme that alginate compared to placebo as add-on once daily PPI in reflux patients with inadequate response. The aim is to evaluate the efficacy of alginate on reflux symptom in patients with persistent symptoms despite once daily PPI. It's a multi-center randomized placebo-controlled trial and have 7-day run-in period, then use a double-blind trial and use HRDQ or heartburn reflux dyspeptic questionnaire to assess the reflux symptom. The eligible patients were randomized to get Gaviscon Advanced 10 ml 4 times a day or placebo in addition to once daily PPI, with the primary endpoint was change in HRDQ score post-treatment compared to baseline. And here are the post-hoc analysis examine, which report in e-poster. You can see that the improvement of reflux symptom, heartburn symptom, and regurgitation symptom is much better in alginate plus PPI, and the responder rates here they define as 3 or more 3 days reduction in the number of bad days during treatment compared to run-in periods. So in this post hoc analysis, they state that compared with placebo plus PPI, Aliginate plus PPI provides significantly better overall control of reflux symptoms as demonstrated by the responder rate analysis, 56 compared to 29, and more symptom-free night like a 51 compared to 27. The same study here, add on, this is HRDQ daily score. This is published in APT in 2016. And the good one is decrease of reflux score and heartburn score significantly. Another study by Japanese doctor, they add sodium alginate to omeprazole in NERD or non-erosive reflux disease, compare between omeprazole plus sodium alginate with the omeprazole alone. And they found that the adding group or group A seemed to be better in terms of complete resolution of heartburn in first 7 days, up to 56% compared to 25%. And heartburn-free day in the first 28 days is up to 54% compared to 36%. So in this study, they conclude that omeprazole plus sodium alginate was better than omeprazole alone in Japanese patients with NERD. And any other position that we can have with the GERD risk. We know that pregnancy is a risk factor of the GERD, right? And here are the prevalence and characteristic of frequent gastroesophageal reflux symptom in each trimester of pregnancy. You can see that frequency, daily symptom, severe symptom, or nocturnal symptom of GERD is increased over time from the first to second and third trimester here, like from 7 at the basal to be 27 at the first trimester, 30 at the second trimester, and 40 at the third trimester, for example. So accumulated weight gain during pregnancy is associated with a higher risk of gastroesophageal reflux symptom in third trimester, and pregnancy might constitute a risk factor for developing gastroesophageal reflux symptom 1 year postpartum. And here is the evolution of the symptom during the course of pregnancy from control first trimester 25%, 35% for the second trimester, and up to 50% in third trimester. And if you look at the quality of life, the higher value indicate higher quality of life. So you can see that GERD group, that the green one here, have a lower quality of life compared to non-GERD in 135 patients in pregnancy. And the frequency of symptom of GERD group is vary from, around, like a 40 or 50% of the patient might have not very much or no symptom here, but in case that they have it, like up to 10% have daily symptoms. And the severity is vary as well from, acid test in the mouth, very mild is around 5%, very severe is around, up to 13% and 23% in moderate group, for example. And when they put the analysis of variable with possible association with GERD, they found that heartburn of mother during pregnancy and chronic heartburn of mother is a significant association with GERD. So look at the result of liquid Gaviscon in the treatment of heartburn in pregnant women. This is a multi-center prospective and open-label study. Population including pregnant women between the age of 18 to up to 40 with current symptoms of heartburn and or reflux requiring treatment. And the intervention including liquid Gaviscon oral suspension at the dose of 10 up to 20 ml as required to relieve symptoms to a maximum dose of 80 ml per day for 4 weeks. And here are the results that evaluated by investigator or by the patient, which were very similar, that the impression very good up to 65% in investigator and up to pretty much the same by the patient. Good is up to 25%. So up to 80% of both investigator and patients also have a very good impression to this treatment. and they decrease the severity of daytime and nocturnal heartburn experienced by pregnant women as well. Okay, so this is the information in pregnancy. And I would like to go back to the guideline again that in WGO global guideline, they state that infrequent heartburn occurring less than twice per week will probably respond to self-care with an antacid or alternate antacid taken once a week or less. Alternate antacid combinations are useful and are superior to antacid alone. At the primary care level, PPIs of a combinations of alternate antacid and acid suppressive therapy can be prescribed at the physician discretion for combination therapy, which may be more beneficial than acid suppressive therapy alone. The OTC medicines, including antacid or alternate antacid, offer the most rapid but usually transient symptom relief and can be taken as required. For the ACG, as in the US, I don't think that they have Gaviscon in their country, but they said that the study with an alginic acid preparation manufactured in the United Kingdom suggests potential efficacy in symptom relief compared with other products, but alginate content of the preparation sold in the other countries is variable. And in the pregnancy, they said that when lifestyle modification fail, antacid, alginates, and sucralfate are the first-line therapeutic agent. For the sole consensus, state that recent meta-analysis show that alginate therapy is more effective than placebo or antacid. For symptomatic improvement of patients with GERD, alginate may be an effective and valuable agent in the treatment of patients with GERD. For the consensus statement, in the Southeast Asia, they state that alginate compounds form a raft above the acid pocket and prevents reflux of acid and non-acidic content of the stomach into the lower esophagus. Alginate should be considered for empirical treatment of patients with mild to moderate symptoms of acid reflux disease, and alginate are good adjunctive therapy for relief GERD symptoms partially responsive to PPI therapy. For Thailand guideline, we state that alginate acts by displacing the postprandial acid pocket and can be used as an additional drug for the control of breakthrough reflux symptoms. A meta-analysis of 14 studies show that alginate increased the odds of resolution of GERD symptoms when compared with placebo or antacid, with the OR of 4.4. Finally, the AGA stated that alginates are useful in neutralizing the postprandial acid pocket, similar, right? And may be particularly useful for patients with postprandial and or nighttime symptoms, and in those with known hiatal hernia. Clinicians should personalize adjunctive pharmacotherapy to the GERD phenotype. In contrast to empiric use of these agents, adjunctive agents include alginate antacid for breakthrough symptoms. This is what they recommend, and I would like to leave my talk with this slide, and I thank you for your attention, and I would like to happy to take any question if you have.
Thank you very much. And thank you very much, Dr. Montira. And this is very, very brilliant and informative presentations that we ever had on the GERD management. And because she is a very eminent neurogastroenterologist, neurogastroenterologist is actually the rare gastroenterologist all over the world. So, and I really, really appreciate that, and congratulations to that. And Dr. Montier, and today Dr. Montier emphasized on the recent publication of the GERD guidelines and the safety and complications of long-term PPI and the misuses of the PPI. This is very useful to us. And also emphasize on the pathogenesis of the GERD and the many illustrative presentation on the acid pocket theory, and which is very essential for the GERD pathogenesis. And there also she discussed on the Aliginate and with the many clinical and scientific evidences of the role of the Aliginate on the add-on therapy with the antacid and add-on therapy with the PPI, and especially in the at many stages of the GERD, mild, moderate, and severe cases, and also highlight on the GERD in pregnancy. This is a very informative topic on us. I'm sure that we all have the very useful information and updated knowledge after the presentation of Dr. Montiel. So let's start the question and answer session. And so first questions here, we have some questions here. First question is, what is she just want to clear that the antacid plus the Aliginate in mild to moderate GERD as a monotherapy. What's your experience, Dr. Montiel?
In my experience, I think usually the position of the Aliginate in my practice is like many of people don't want to stay on with the medication every day. So I would like to will ask them first, like what is your concern? Like maybe it's not just only symptom that they're concerned, but it's they are scared of the development or progression of the disease to be cancer, which you can explain to them that as in Asian country, they are very low, Los Angeles classification class C and D, which is more severe. But in our countries, it's like just only LAA or LAB, which is mild, or in some paper, they are changed LAA to be NERD already. So if they're concerned about the transformation into cancer, you have to inform them that it's very low risk to be in that case. So if the patient's concerned about their symptom, like the symptom disturb their daily life, I will ask them like how often that you get the symptoms. If it's not very often, I would recommend the short, the rapid action, which is the Gaviscon or Aliginate. It's very rapid in terms of action. But in case that you have kind of more severe, almost every day, I would recommend the PPI. Yeah, between the antacid and Aliginate, in my experience, as they are usually get antacid from drugstore already, so I have to change my practice anyway. Yeah, that's the way. Yeah. Mm-hmm. And in the meta-analysis that I show you, that there are comparison of antacid or placebo compared to Aliginate, and it seems to be that Aliginate is much more better. Yeah.
Thank you very much. And another question is about this is beyond the scope of our presentation, but he wants to know about the rules of the diet on the GERD exacerbation. So we are Thailand and Myanmar, so we are the same, the pattern of the diets. And so what's your experience?
You mean if we could not get the endoscopy?
Yeah.
Can you ask me? Yeah, okay.
Diet and GERD exacerbation.
Diet?
Same food pattern in both countries. So what's your experience in our diet? And yeah.
Okay, so in terms of diet, actually, if you are looking at the Thailand guideline of GERD, we also have, we also mentioned about that, but in my experience itself, usually I will recommend the patient to get like a regular meal time. Like if you have breakfast in the morning, like at 7, you have to stick with that. If you change your time a lot, it will alter your GI working. So, but the kind of foods that I usually recommend the patient to avoid, and there are some evidence that show that spicy food and fatty food usually aggravate the symptom, but it's not in all patients. Around 25 up to 30% of the patient get this effect. So I will ask them to try it. Like if you think which food is bother you, even if it's not spicy food or it's not fatty food, but if you try it like 3 times and it's still there, it will happen. So you have to avoid it. But general recommendation for me is usually spicy food and fatty food that you should avoid. Yeah.
Thank you very much. And we are the same pattern of the dietary habit in both countries. And so they now using in our country, they now taking very, very spicy food later in these years. And I think it may be sometimes exacerbated, but not much of that, I think. Yeah. And another question is, do you have any, I mean, do you think any difference between the different PPI on the treatment of GERD?
Different PPI. Theoretically, I would say that it's not very different in terms of efficacy. For example, if you use healing of esophagitis as a result, you can see that most of the time at 4 or up to 8 weeks, healing percentage of the healing of esophagitis is up to 90%, and it's comparable between PPI. But if you look at individual study, it might be some some PPI have a superior in terms of pH control, or in some study that say that PPI-A is superior to PPI-B in terms of HP eradication. So it's kind of very varied. So it depends on what are you going to treat. If you treat their symptom, I will start with the lower one. I mean the cheap one, the omeprazole one firstly. But in case that they don't don't respond, I might have to change it. But if you're looking at in the question, the doctor asked if different between esomeprazole and lansoprazole. In I would say overall evaluation, it seemed to be that these, I mean both of them, very good in terms of efficacy compared to omeprazole. I think it's kind of comparable. Yeah,
I think so. Yeah. And so what about the CYP2C90 status in your country? I think the same as Myanmar. I think we have the one study and the same as Thailand. So it's not much to, I mean, rely on that, I think.
For the CYP2C, yeah, what the professor said is right. It depends on the patient as well. In Thailand, around 30% of them have rapid metabolizer. So PPI will go away very, very rapid. So in these cases, the longer duration of the medication will help. So in that case, the evidence state that esomeprazole or dexlansoprazole have longer duration compared to others. But I think you can, if you have them have a BID dosage, in case that you don't have another, you don't have the medication that I mentioned, you can try a BID dose as well. Yeah.
And thank you. Another question is, what about the clinical diagnosis of the GERD for the very resource poor setting? Any, I mean, the benefits and any risks for that if they don't get any other facilities especially in the remote area?
Yeah, I believe that you mentioned you're thinking about endoscopy and 24-hour pH monitoring, right? If we have a limited resources, Thailand also have limited resources, But in my hospital, maybe it's a tertiary care, so we have many of investigation that we can provide. But I'm not going to do endoscopy in every cases anyway. So usually, if I will start with you. If the symptom is compatible with GERD, I will ask if they have, alarm symptom or something else that you're thinking. If they are not, you can empiric treatment. And the empiric treatment can be, it's depend on the symptom that I mentioned before, that it's my symptom or it's a severe symptom. So you can customize your medication. And the most importantly, I think is maybe the the understanding of the disease that patient need to understand, and don't have them like a scare with cancer because in publish or in the media, usually they will promote the medication by saying that okay, GERD will increase the cancer, which is right, but it's not very common in our country. So just make the patient comfort in that case. Yeah, and in case that intractable cases, you might have to do endoscopy. Just only intractable case. Yeah.
Okay, thank you. And another question is any role of prokinetics in GERD?
Yeah, this is kind of I think it's a debatable topic. There are some study that say okay, this is good for GERD, but it's not all of GERD. Usually the study that support the use of prokinetics will study in terms of physiologic change, and in my experience I will use it in case that have like a dyspeptic symptom together with GERD symptom. So that's mean your stomach, it doesn't work well, and if your stomach it doesn't work well, your esophagus will not not work well as well. I actually just have myself experience with GERD this early month. I never had it before, and I just understand why it's it kind of suffering a bit. Yeah, so I understand that. And if you say that prokinetics, it's usually I will add in case that patient have like a dyspeptic symptom, but in pure GERD symptom like heartburn or regurgitation, PPI is enough. Yeah.
Yeah, thank you. And another question is role of baclofen in GERD.
Baclofen, it have a role if the patient have like the theory of GERD is that your lower esophageal sphincter is relaxed more more frequent than usual, and the baclofen will help with cases that have weak lower esophageal sphincter contraction. But in my experience, again, usually people report a lot of side effects like dizzy or sleepiness or something like that. So I usually don't use it as a first line. Just consider in some cases, especially if I can test for the function of LES. Yeah.
Okay.
And you have to talk to the patient, like you have to this to be expected, something like that. Yeah.
Thank you very much. And then another question is asked by Professor Chola, our mentor, and he asks on the any endoscopy and surgery in GERD in the our patients, in here, and most of the patients you already mentioned is NERD rather than the GERD, and complicated GERD is really rare here. But what's the experience, and please share with for that.
So usually for the surgical cases, usually I will consider in case that I have a refractory GERD. That means they are not response to like full medication, for example, PPI BID plus or minus Aliginate add-on. And if the patient is not improved, you have to study about the manometry to see, because many of them that when I did it, we found that they are weak peristalsis or is ineffective esophageal motility. That's why they could not clear the acid very well. And in that case, you have to talk to them about the result of endoscopic finding, endoscopic treatment, like fundoplication, things you can consider it, but the data is not a large data to say that okay, you get successful of the treatment. So and you have to talk about the side effect of the treatment as well. Yeah, and let you have to make the decision together with the patient and give them enough information, I think.
Yeah. Okay, thank you very much. And another one, I just want to ask about it. Any role of the PCAP instead of the PPI in cases of the GERD? What about its long-term safety?
The PCAP itself, I think it's good in some cases. Like I mean, in terms of efficacy itself, as the researcher designed as a non-inferiority trial. So we just say that okay, PCAP is not inferior to PPI, right? But in subgroup of the patient, like in my experience, he just came to see me yesterday. He's a Barrett esophagus case, and I did like a PPI BID for years, but his symptom is still it's not improved. But then PCAP comes, and I gave him, I follow up endoscopy. It's absolutely good. Like right now it's normal already, and his symptom is went away. It's gone away already. So usually the data state that in GERD, LAC and LAD and Barrett esophagus, PCAP is good, but it's more expensive. So yeah, that's the thing. Yeah, I think.
And another thing I just want to ask is the Aliginate is, as far as I know, it is very safe. But in long-term use, do you have any experience on its side effects?
Not really. Usually, if the patient didn't take it because the test, because like it's like myself, I don't like the liquid thing. So yeah, but when I got GERD this early month, I went to Kanchanaburi, which is far from Bangkok, and I could not get the medicine. They have just only Gaviscon, RX, and domperidone, and I get all of them, and it's worked very well. It helped a lot. Yeah,
it's very strong evidence.
yeah.
Thank you very much. And so we have another, or the one answer. Any role of Aliginate in H. pylori infection? As far as I know, there is nothing. No, I think yeah.
No, I don't think so. Yeah.
So these are very. So we answer you answer all the questions, and you touched every aspect. Actually beyond our topic today. So thank you very much for your very lively presentations, and I really appreciate that. And I hope that we can see each other again. In Thailand or in Myanmar.
Yeah, thank you very much. And thank you for our attention from our doctors there, and hope to see you again. Yeah.
Thanks a lot.
Thank you.
So much and please. So I like to hand the presentations, the webinar to our farmer company. Type the sign. Yeah. Type the sign, please.
Thank you, Professor Nani and Associate Professor Montira for the scientific information. And then I am kindly request to you all to present the Gaviscon product presentation. Maybe you all know, I would like to kindly remind that Gaviscon is the best choice for gastroesophageal reflux disease and heartburn suffering patients. Gaviscon is the best solution for the GERD, which is mechanical problem. This is because Gaviscon contains unique Aliginate compound, which start as a red layer on top of the gastric acid and gastric content. Gaviscon action start within 3 to 5 minutes and its action lasts up to 4 hours, which is effectively beneficial to your GERD patients. With the combination with PPI, Gaviscon can give optimizing treatments to GERD patient who is suffering with residual symptoms with PPI treatment alone or PPI with antacid combination. Sodium bicarbonate and calcium carbonate in Gaviscon also as acid neutralizing agents. As Gaviscon is registered as over-the-counter drug, you can safely use in many types of patients, including pregnancy and lactating mother. As a conclusion, I would like to kindly remind you all to choose the Gaviscon liquid sachet for your GERD and heartburn patient. Thank you so much for your kind attention and joining our online event. Thank you all.
So thank you very much for your very interesting information on the Aliginate and Gaviscon. So I think we better close our webinar successfully. Dr. Montier. Dr. Montier. So I just want to thank all the audience and the present our eminent presenter, Dr. Montier, and all the, especially our attendees, Prof. Chola and my seniors, and all the colleagues, and to spare this your precious time, especially in this afternoon on our topic and role of Aliginate on the management of GERD. So our webinar is successfully accomplished, and so I just want to close the session. Today's session was very successfully. Thanks for all. We go like that.